It's a genotypes of A9, HLA B5, and HLA 54 genotypes, probably with immune response, hypertension, diabetes, mellitus, hyperlipidemia. It's all risk factors of thromboarteritis obliterans. There are three phases of thromboarteritis obliterans. Acute phase. An initial inflammatory process forms an intraluminal hypercellular and inflammatory thrombus, which occludes the affected vessel's lumen. Generally, there is a sparring of the vessel wall. Although local inflammation is central to this acute phase, inflammatory markers such as the C-reactive protein and erythrocyte sedimentation rates are typically normal. Subacute phase. The thrombus organizes in the setting of the ongoing inflammation. Chronic phase. The inflammatory process subsides and non-inflammatory fibrotic thrombus forms. In all phases, the internal elastic lamina is preserved in contrast to atherosclerotic or vasculitis. So in this scheme you see pathogenesis of thromboarteritis obliterans during the smoking, and the main process it's oxidative stress and change of antioxidants. In the genetic variation and changes of oxidation, we see changes of neutrophils, macrophages, and in this machines you see the changes during the process. If we see risk of oxidant stress, we will see the disease will be occur. Another scheme. In this scheme, you see the role of the interleukins anti-inflammatory response and role of the different cells. The dendritic cell, naive T cell, macrophage, mast cell, eosinophil. Fibroblast and fibrosis of fibroblast will lead to the fibrocytes, and you will see the formation of thromboarteritis obliterans. And you see in this slide you see the changes which leads during the inflammatory process. Injury to blood vessels, it's genetically susceptibility in individuals. Innate and adaptive immune response in this process, and high intraluminal thrombus formation. And it's not depends of the types of the cigarettes, and if you smoke electronic cigarettes and other forms of nicotines also we will see the changes and high risk of inflammation process, formation of thrombus, and which leads to endothelial dysfunction and formation of thromboarteritis obliterans. Patients with this process. So, clinical picture. There are 10 main signs. It's an intermittent claudication, constant dull pain, coldness, paresthesia, fatigue, changes color of the skin, local hyperemia of the skin, trophic changes, edema, ulceration, and gangrene. Intermittent claudications occur in defense of muscular ischemia, which inadequate to blood supply at exertion. Manifest by pain, fatigue, feeling, permanent cramp, severe itching, or compressive pain that occurs only after a certain amount of exertion of the affected muscles, and that is revealed promptly by rest without changing position. So the intermittent claudications occurs most commonly in the arch of the foot, less commonly in the lower leg. However, it rare affects the thigh and hip. And there is a Fontaine classification with various. It's a types of claudication and 4 stages of chronic lymphocytemia. First stage, it's a claudication on a distance more than 1 kilometer. were a sign of a skin blood insufficiency, pallor, temperature, numbness, and paresthesia. 2A stage, claudication moving in 200 meters. There are some new signs of skin blood insufficiency. 2B stage, claudication earlier than 200 meters walking. There are skin atrophy in Buerger. First stage, the claudication at rest or walking less than 25 meters. Fourth stage, it's also necrotic stage with a severe constant pain syndrome. Another classification Rutherford, and when we compare with the Fontaine classification, we see there are 6 stages of the Rutherford classification and 4 stages of, but all clinical picture is the same. In Rutherford classification, asymptomatic it's a 0 stage, mild claudication 1 stage, moderate claudication 2nd stage, severe claudication 3rd stage, ischemic rest pain 4th stage, and manual tissue loss 5th stage, and 6th major tissue loss. And it's a picture of stages. It's a 4th stage, also necrotic stage with severe constant pain syndrome on the right foot. Also, we can see the picture in the arms, ulceration, gangrene. In the digits. Also formation of fissures of the heel, ulcers, gangrene. Costal dull pain. Buerger is associated with the irritation of osteoreceptors of ischemic bones of foot. Coldness. Sign of a pathology if it's asymmetric or in its occurrence in a warm environment, where sensation of cold occurs simultaneously with objective coldness of skin, disorders on sensitivity and pain. Paresthesia. With circulatory insufficiency influences of the function of nervous system. It manifests frequently by cramps and paresthesias of the lower limbs, which should be regarded as ischemic changes. Fatigability arises from the generalized spasm of collateral vessels at walking and physical exertion. Changes color of the skin. Depending on the disturbances of the peripheral circulation, the skin may have a blanched, cyanotic, or abnormally red discoloration in the advanced stages. Functional and organic changes of arterial permeability are revealed, and the collateral circulation has not been developed yet. Branching of the skin becomes in the particular sharply expressed and constant. Local hyperemia of the skin. It's so-called hyperemia of tissues without rising of the temperature, which is caused by blood circulation. Meanwhile, venous thrombosis, necrosis, and gangrene are mainly displayed by cyanotic or dark brown discoloration of the skin. You see the picture of the hyperemia. Trophic changes. A sweating of legs, which in the following stages gradually one disappears. The skin loses the normal elasticity, becomes dry, and has fissures. The toenails may become distorted, where growth is precariously slowed, or they thickened and horny. The same changes result in the development of the flat foot, atrophy and muscles, and manifestations of the diffuse or spotty osteoporosis of bones. Edema constantly accompanies with necrosis and gangrene. Considerable role is applied by the arteriovenous and lymphovenous anastomosis, where prompt dumping of arterial blood into veins results in increase of venous congestion and intensive transudation. It in turn increases the hypoxia of tissues and leads to the accumulation of down-oxidated substances. They manifest by the thrombophlebitis, the pathological process in veins reflectively worsens the arterial circulation. The spasm of the arteries which accompanies it causes cyanosis, which is called a blue thrombophlebitis. Ulceration and gangrene develop on the tips of the digits in the fold at the base of the between the toes, vicious ulcer. Seen around when the atrophic cyanotic abnormally red and with the slight inflammatory manifestations, ulcer is such patients pain and the pain mostly troubles at night. The progression of necrosis results in gangrene and the spreading of it in proximal direction is preceded by tissue edema. Clinical course of the disease. I said 3 variants: acute, subacute, and chronic. An acute genoid malignant usually occurring in young patients from 80 till 25 years, when the process becomes systemic in the period from the 3 months or 1 year. Subacute and from the exacerbation and remission of various duration, and chronic, gradually progressive disease develops over many years with a long period of compensation for regional blood circulation without severe exacerbations. This is the most favorable option. Chronic course is more often observed in patients aged 35 years and subsequently often combined with the atherosclerosis. Differential diagnostics. We will differentiate with antiphospholipid syndrome and pregnancy, atherosclerosis, frostbite, giant cell arteritis, gout imaging, imaging of polyarteritis nodosa, Raynaud syndrome, scleroderma, systemic lupus erythematosus. Type 1 diabetes mellitus and type 2 diabetes mellitus. Because of a lack of a clinical or laboratory indicators of Buerger disease, and the frequent difficulty in the differentiated thromboangiitis obliterans from other vascular pathologies that might affect the extremities, a number of criteria have been published. The simplest criterion of the synoia, which consists of the presence of 5 mandatory items: history of smoking, first, second, beginning before the age of 50, third, intrapopliteal occlusive lesions, fourth, involvement of upper limbs or migratory phlebitis, 5. Absence of atherosclerotic risk factors with the exception of smoking. Diagnosis. Blood test can help to rule out scleroderma, lupus, blood clotting disorders, and diabetes. Capillary finding. Crossed leg test, reactive hyperemia test, an angiogram or an arteriogram of the upper and lower extremities, a Doppler ultrasound, echocardiography. Skin biopsies are rarely used because of concern that the biopsy site near an area with poor blood circulation will not heal. So, and you need to remember the points of pulse. And on these slides you see the main points, but usually we use the points where we check in the pulse in the extremities, in the upper extremity and the lower extremity. It's radial, brachial, femoral, popliteal, dorsalis pedis, and posterior tibial. Femoral pulse can be found along and location. Some words about of location of points to remember, to review of this. Along the crease midway between the pubic bone and the anterior iliac crest. Use the tips of your second, third, and fourth fingers. If there is a lot of subcutaneous fat, you will need to push firmly. Popliteal. Bend the knee slightly. Place your hands around the knee and push the tips of your fingers into the popliteal fossa in an effort to feel the popliteal pulse. Note whether it feels simply pulsating, normal, or enlarged and aneurysmal, uncommon. Tibial posterior artery. Its location is the medial malleus, and we can use the second, third, and fourth finger behind the malleus, and we can feel the pulse. If there is a lot of edema, you will have to push your way through the fluid-filled tissue to get down to the level of the artery. If you are unable to palpate and pulse a Doppler machine and use it to identify the location of the artery, you see the Doppler scanning, it's a sound scan, and on this picture, mark the place with the pen, and then the go back and again try to fill it with your fingers. In this way, you will be able to determine if the vessels was not palpable on the basis of limited blood flow, or if you are simply having a technical problem. Auscultation reveals the movements and vascular bruits. The stethoscope is placed over a pulsating artery. And here you see the abdominal aorta, here it's a femoral artery. For example, decreased amplitude of the femoral pulse along with the loud breathing. Proximal of the iliac artery usually indicates the presence of a significant iliac stenosis. With complete occlusion, no pulsation or bruits are present. Ankle brachial pressure index. What is it? It's a instrument which helps to doctor to imitate the problems with arteries. Ankle brachial pressure index is ratio of the systolic pressure at the ankle to that in the arm. And normally is a 1, if not more. 0.5 and 0.9 can be associated with claudication. When the not more 0.3, it suggests imminent necrosis. Do you keep up with me? Students? Okay. Contraindications for the measurement of ankle brachial index. This is not done in a patient with deep venous thrombosis, as this cold causes a dislodgement of the thrombus. Duplex ultrasound study should first be done to exclude this possibility before measuring the ankle brachial. And the presence of the thrombus. And you see the examples of the Doppler scanning of the dorsalis pedis arteries, and in the modern scanning we will see on the screen the waves and normal triphasic waveform of peripheral arteries, arterial high resistance flow. It's a narrowing frequency band, steep systolic increase, quick drop, early diastolic reverse flow, and late diastolic short forward flow. So now you will see the video how we check the ankle brachial index.
Welcome to a Stanford Medicine 25 video on ankle brachial index.
Hi, I'm John Cook. I'm a professor of medicine in the Division of Cardiovascular Medicine here at Stanford, and today I'm going to show you how to detect peripheral arterial disease in the office setting using the ankle brachial index, which is simply a measure of ankle pressure divided by the pressure at the arm, the brachial pressure. There are about 8 million people in the country with peripheral arterial disease, but only about 30% have been diagnosed. So with a simple handheld Doppler and a blood pressure cuff, measurements at the ankle and at the arm can give you an ankle brachial index to tell you whether or not the person in your office has peripheral arterial disease. Everyone over the age of 60 and anyone over the age of 50 that's diabetic or smoker should have this test done to determine if they have peripheral arterial disease, because we have life and limb-saving medical therapies for these individuals, like ACE inhibitors and statins and antiplatelet agents, and even beta blockers can be used in patients with peripheral arterial disease. So let's get started. So for the ankle brachial index, we need a handheld Doppler, and we also need some ultrasonic gel, and we need blood pressure cuff. We want the patient in a dimly lit, quiet room for about 10 minutes, relaxed, so the blood pressure stabilizes. Okay, so what we're going to do first is measure the pressure at the arm, and we're going to use the same technique to measure pressure at the arm that we're going to use to measure pressure at the ankles. So I'm putting the blood pressure cuff around the arm right now. You want it to be snug, and now I'm going to put some ultrasound gel right here in the antecubital space over the brachial artery. So my fingers are on the brachial artery there. Having done that, now I can listen for the signal with my handheld Doppler. Now, that's a nice signal. It's a normal triphasic pulse waveform that we're hearing with our Doppler. Okay, now what we're going to do is we're going to blow up the blood pressure cuff until we no longer hear a signal. Okay, and we're going to gradually release the pressure until we hear the signal again. Okay, he's got a blood pressure of 100 millimeters systolic. So that becomes our denominator for the ankle brachial index. Now, there are two vessels that we're interested in in measuring the ankle brachial index. So 2 vessels in the foot. One is the dorsalis pedis, which is right about here, where my finger is. The posterior tibial is right behind the medial malleolus. If you can't feel the dorsalis pedis bilaterally, it could be normal. That could be a normal finding. But you should always be able to feel a posterior tibial artery. If you can't feel the posterior tibial artery, that's always abnormal. So once again, you apply the blood pressure cuff, and in this case, we're going to be applying it right above the malleoli. Again, you want it snug, and you'll put the gel right behind the medial malleolus and the over the dorsum of the foot. So let's just take a listen to the waveforms here. So that's a very nice pulse waveform, strong, biphasic, and that's normal in an adult. And let's just take a listen over the posterior tibial. Nice pulse waveform there. Now, let's check the pedal pressure. Okay, I've blown the cuff up and I'm slowly releasing it. And that was about 110 millimeters of mercury. That roar that you just heard, that was venous return. I'll actually demonstrate that. This is the arterial signal. You can hear that. I'm going to squeeze the foot, and you'll hear the venous return moving past that Doppler transducer. That's venous return. We'll talk about the venous exam at another time, but one can determine if someone has a venous obstruction or venous insufficiency using this handheld Doppler. Now, I've shown you how to do the posterior tibial pulse waveform, get the pressure there. You do the same thing over the anterior tibial. You do that for both pedal pulses in each extremity. And then what is done to create the ankle brachial index is you take the highest of the brachial pressures that you've measured, and that becomes your denominator. The numerator is the highest ankle pressure in the right leg and the highest ankle pressure that you've measured in the left leg, to give you the right and the left ABIs respectively. Sometimes you may find that the pressures are slightly different between the anterior tibial and the posterior tibial artery, and by convention we express the higher of those two pressures over the brachial pressure to get the ankle brachial index for that foot, and we calculate the ankle brachial index for each foot.
To conclude with the example in our video, the patient's highest right ankle pressure was 110, which is divided by the highest of the blood pressures in both arms, which was 100, giving a right ankle brachial index of 1.1. An ankle brachial index of 1 to 1.4 is normal, whereas a value of 0.9 to 1 is acceptable. Neither require any intervention. A value of 0.8 to 0.9 suggests some arterial disease, and treatment of risk factors is advisable. A value of 0.5 to 0.8 suggests moderate arterial disease, where a value of less than 0.5 suggests severe arterial disease. Either category should be referred to a vascular specialist. And finally, a value greater than 1.4 can be an indication of calcification or vessel hardening, which also should be referred.
So, investigations of arterial stenosis or occlusions, Doppler ultrasound, blood flow detection, duplex scanning, treadmill test, arteriography, and digital subtraction angiography. Treadmill test. Patients themselves are poor at assessing indicating distance, and it might be for with treadmill. Assessment would provide a useful objective measurement of distance of onset corridor is even more reliable. A good use for the treadmill is the detection of a fall in ankle brachial index after exercise. Indicating occult arterial stenosis. Duplex ultrasound scanning is performed to determine the location and severity of arterial lesions. Specific arterial examinations include the abdominal aorta, common and external iliac arteries, common and superficial femoral arteries, popliteal, posterior tibial, anterior tibial and peroneal arteries. Duplex scanning. Duplex scanner uses a B-mode ultrasound providing image of vessels. A second type of ultrasound beam is when we use the resonate the image vessels. Two types of information are obtained hence of the TOM duplex ultrasound, an image of the structures and information about of blood flow. So in this picture you see the color duplex scanning of the showing severe stenosis of proximal tibial fibula trunk. And what does it mean, red and blue color? Usually students answer to me in the classes, it's arterial and venous blood. It's wrong. And this color means the ways of blood, and it means to the scanner red color, out of the scanner it's a blue color. And here you see the Doppler color imaging. Arteriography is an important image examination for confirming the diagnosis of Buerger disease. Examination of findings which suggest thromboarteritis include multiple segmental occlusions of medium and small size arteries, mainly below the knee, line, and elbows, and the presence of collateral arteries adjacent to the areas of occlusion, classically described as a corkscrew shape, Martell's sign. And on angiography for visualization of extremity vessels in the thromboarteritis obliterans, there is a high spatial and temporal resolution. It reveals narrowing and tapering of the affected digital vessels. And in the left angiography, you see the absence of branches of vessels. It's a Buerger disease. And here you see the changes of vessels and poor blood supply of the distal parts of the feet. Femoral artery angiogram, demonstrating the complete occlusion of the left femoral artery. You see absent blood supply of the artery. Transcutaneous oxygen pressure measuring provides instant and continuous information about the body ability to deliver oxygen to the tissue, and the index of progressive decreases in patients with arterial insufficiency. Capillaroscopy, to investigate the size and appearance of the capillaries in the nail. The fingers are placed under the microscope and a drop of olive oil is placed on the nail bed to improve the visualization of the capillaries. Interpretations of results. It's a normal capillaries. The capillaries are hairpin in shape and regularly spaced and numerous. Characteristic anomalies include the capillary enlargement, giant capillaries. You see the giant capillaries. If you compare with the normal, it's big changes. Avascularity, absence of vessels. Hemorrhage. Areas of hemorrhage indicates the deposit of macedorine extending up from the capillaries. And arrangement. The normal capillary architecture is disturbed. Also, angiogenesis. Capillary loops with multiple epices sometimes describe a bushy or ramifield. You see the changes. Biopsy. Biopsy is not routine in the diagnosis of thromboangiitis obliterans, reserved for the causes of diagnostic doubt. The histological findings depend on the stage of the disease. In the acute phase, it includes the occlusive thrombus with inflammatory characteristics and high cellularity, but with less inflammation in the walls of blood vessels. Polymorph nuclear leukocytes, microabscesses, and nucleated giant cell may exist in the intermediate phase, in which there is a progressive organization of the thrombus in the arteries and veins. Finally, in established disease, there is a well-organized thrombus with fibrosis. It's an end stage. The disease develops progressively, so it's important to start treatment in the reversible functional phase of the disease. Conservative treatment. The most effective treatment for Buerger disease is to quit smoking. All possible means should be used to encourage patients to give up the use of tobacco in all its forms. Theological help may be useful in certain cases, but patients should be reassured that if we manage to give up smoking completely, the disease will go into remission and amputations can be avoided. Selective cannabinoids receptor antagonists such as Rimonabant have shown good results in helping patients quit smoking. Supportive measures. Gentle massage and of increased circulation. Avoiding conditions that reduce the peripheral circulation like cold temperatures. Avoid sitting or standing in one position for long periods. Avoid fit of restrictive clothing. Patients who have a claudication but not critical ischemia should be encouraged to walk, and whereas those with a critical ischemia should be admitted for a bed rest. Pharmacological treatment. In patients with Buerger disease is an alternative for selected cases when the disease presents as diffuse and severe limb ischemia, such a critical presentation possibilities for revascularization and greatly diminished. Therefore, the pharmacological agents are used to improve perfusion. So, drug treatment. First main drugs it's a prostanoids, prostaglandin analogs, and prostacyclin, and maybe you saw the iloprost. It's a relief pain and heal ulcer. Prostanoids are derivatives of the ecosanoids and are commonly used in the treatment of numerous disease, including the pulmonary hypertension, sexual impotence, and glaucoma, and so on. Prostanoids act by the binding to the specific receptors in the endothelium, and platelet inhibitors platelet aggregation, which causes a transient increase in peripheral perfusion. Arterial vasodilatation in ischemic areas increases blood perfusion and consequently increase the chances of the healing of the ulcer and improves pain at rest. By inhibiting platelet aggregations, the occlusion of small and medium-sized arteries is prevented, and in the theory also stabilizes the disease. Due to their short half-life, about of 2-3 minutes, these synthetic drugs should be administered by continuous intravenous infusion. The never stable prostacyclin analogs with a longer half-life have allowed the oral use of these drugs. The most important contraindications are heart failure, intracranial hemorrhage, gastrointestinal disorders, and trauma. Side effects include the headache, flushing, malaise, gastrointestinal disorders, and hypertension. Telostazole is a pharmacological agent frequently prescribed to patients with peripheral artery occlusive disease of atherosclerotic etiology. Pharmacological telostazole is a derivative of quinolone and drug that inhibits specifically the type 3 cellular phosphodiesterase, which affect reversible inhibition of the platelet aggregation and inequally vasodilatation of the vascular beds. In other words, telostazole steals a small part of the blood from the other territories to improve the perfusion in ischemic limbs. Telostazole is contraindicated in patients with congestive heart failure, hemorrhagic disturbances, or current bleeding, such as gastrointestinal or intracranial bleeding. And in the individuals with known with suspected hypersensitivity to telostazole. Side effects of telostazole include headache, diarrhea, abnormal stools, and tachycardia. Telostazole is given orally and fasting at a dose ranging from 50 to 200 mg per day. Bacetan is a powerful double antagonist of endothelin receptors, causing selective vasodilators effects. Bacetan has been used successfully in patients with digital ulcers and systematic sclerosis. Some important reported side effects are hepatotoxicity and fluid retention. Bacetan is given orally, primarily in patients with pulmonary arterial hypertension, with a recommended dose 62.5 or 125 milligrams twice daily. Rheologic agent, pentaxyphylline or methylvaxtin derivative is the only hemorrhagical active agent currently approved by the Food and Drug Administration for treatment of intermittent claudications, improve abnormal erythrocyte deformability, reduce blood vascularity, decrease platelet reactivity, and plasma hypercoagulability. A critical review of these trials conclude that the actual improvement in walking distance attributable to pentaxyphylline is often unpredictable, may not be clinically important compared with the effects of placebo, and does not justify added expense for most patients. The drug may have a role in rare patients with a reduced walking distance who cannot increase therapy or who do not respond to the exercise treatment. Anticoagulants, heparin, warfarin. Anticoagulant therapy includes the direct and not direct anticoagulants, and If we speak about of direct anticoagulants, we can use the unfluctuated heparin and low molecular weight heparin. And you see the examples of the low molecular heparin. It's dabigatran, argatrovan, and now we have a not direct anticoagulants, which don't need the control of the laboratory controls. It's rivaroxaban, apixaban. It's activated factor 10. Antiaggregants. Aspirin, 70.75 milligrams day orally is the drugs with antiplatelet and anti-inflammatory properties, often used to prevent arterial occlusion, and pharmacologic aspirin inhibits the cyclooxygenase, the enzyme responsible for the synthesis of thromboxane and prostaglandins. Contraindications are hypersensitivity to salicylates, active gastrointestinal ulcer, and use in children, patients with active hemorrhage, renal and hepatic failure, and pregnancy. Aspirin is given orally at recommended dosage and from 75 on 325 milligrams. Clopidogrel, also it's antiaggregants, and it's a modern drugs, and we can administer for 75 milligrams a day orally. Non-steroid anti-inflammatory drugs can help to with patients any kinds. And one of examples is ibuprofen, where you can administer 1,200 milligrams a day orally. Also, we can administer vitamins, vitamin E, vitamin groups B, first 6, 12 for this patient. And now we have approved medicine, and all these agents have a low efficacy reported in a series of cases, and therefore with a very low level of evidence. So exercises which can help to patients with thromboangiitis simplex. It's a Buerger exercise. It's a procedure, a 3-stage exercise procedure carried in 3 times a day. First position, patients lies supine with the legs elevated and supported at a 45 or 60 degree angle. After that, maintain position for 1 to 3 minutes or until blanching of the extremity occurs, and actively dorsal flex and plantar flex the feet. And termination exercise to the Buerger exercise. It's the elevation of the limbs and discontent if pain or cramping of the calf muscles occurs. And contraindications. It's recent acute thrombosis or embolus, increased swelling in the lower extremities. A rush of exercise. The lower extremities are elevated to the 45 to 90 degree angle, and ankle joint rotation is exercised until the skill blanches. The feet and legs are then lowered below the level of the rest of the body until redness appears. A positive effect is achieved by the repeating and carrying out this exercise several times a day. And you see the rush of exercise. Principles of surgical treatment of thromboarteritis obliterans. First principles, it's a revascularization, direct or not direct, minimally invasive or invasive. Surgical interventions, radical, it's angioplasty, vascular bypass grafting, thromboarterectomy, amputation, and palliative, it's a sympathectomy. So angioplasty or percutaneous transluminal balloon angioplasty is an endovascular procedure to widen narrowed or obstructed arteries or veins, typically to treat arterial atherosclerosis. It can use in the coronary, peripheral, carotid, renal artery, and venous angioplasty. And clinical effects, inadequate size and or quality of excess vessels. Risk, it's embolism, hematoma, pseudoaneurysm, arterial rupture, and injury. Techniques, it's a percutaneous access to the vascular system, insertion of the introducer sheath into the blood vessels, Weissendinger techniques, fluoroscopic and radiographic contrast dye, guidance of inlet wires and catheters, wire placed at site of stenosis, balloon or catheter placed over wire, verification of position via fluoroscopy, inflate balloon using water mixed with contrast dye, place stent and remove balloons, wires and catheters. Treat vessels punctusitis with the pressure or vascular closure device. And you see the Seldinger techniques. We use the needle after put the wire, remove the needle after we put a special catheter and remove the wire and stay the catheter for this procedure. And use the balloon with stents and expansion the lumen of nerve arteries. There are 5 types of stents, currently type stents available. It's a dual therapy stents, bioabsorbable vascular, bioengineered stents, drug-related stents, and biometal stents. And you see the picture of arteriograms, patients with disabling claudication of the left leg and focal stenosis of the superficial femoral arteries. Is after percutaneous transluminal angioplasty, and you see the recovery of the blood supply of the leg. Так, one video about balloon angioplasty.
Peripheral arterial disease, or PAD, occurs when a blockage forms in the artery blood vessels of the leg or thigh. This blockage often causes pain or fatigue in the leg, thigh, or buttocks during walking or exercise. Critical limb ischemia, a severe form of PAD, may lead to foot ulcers and leg pain, even at rest. A minimally invasive procedure to treat critical limb ischemia may be available from your interventional radiology doctor. Your doctor begins by inserting a guide wire into the femoral artery in your thigh. Sometimes the leg opposite the side of the symptoms is used for initial access. A tapered sheath is then inserted over a wire to provide easy access into your blood vessels for the small tools required to perform the procedure. The wire is then advanced to the area of blockage, and your doctor will cross the blockage with the wire and a catheter. Once the wire has successfully crossed the blockage, a deflated balloon is advanced over the wire to the site of the artery occlusion. When the balloon is inflated, it opens the blocked artery and restores blood flow. The doctor collapses the balloon and removes it completely. Sometimes, if the artery remains partially blocked, a stent or metal scaffold is used to keep the artery open. In its collapsed form, the stent is loaded onto a catheter that is then inserted over the wire to the site of the artery blockage. The stent is then opened, detaching from the catheter and allowing the catheter to be removed, leaving behind the open stent within the artery. The stent will help prevent the blockage from reoccurring. For longer artery blockages, several stents may be required. A new variation of this procedure has been developed for more complicated artery blockages. The blocked blood vessel is approached from both the femoral artery above and from the foot or ankle below. Wires and catheters are advanced to the blocked artery from both directions until the blockage is crossed either from above or below. Once the blockage is crossed from either above or below, the procedure is completed as usual. The doctor can then inflate an angioplasty balloon and stent, if needed, to reopen the artery. Once the artery is satisfactorily opened, all the tools such as wires, catheters, and sheaths are then removed. The femoral artery access in the thigh is sealed, and the patient can usually go home within 4 to 6 hours. At the end of a successful procedure, it is important to decrease your risks for future blockages by committing to making lifestyle changes, including quitting smoking, taking prescribed medications, and exercising. These changes can go a long way to helping you live a longer and healthier life.
And next operation, it's bypass operations. We can use the stents or stent grafts, and we can use the autotransplantants. We can take superficial lymphovenous vein and make the bypass operation. The patient had amputations and take the right leg, which is make the operation, the bypass operation. The popliteal artery. Common femoral artery. This is the great saphenous vein. We have an autotransplanter. If you recover the blood supply to the region, Albatros contact is moved and compensate proximal standards. Distal stenosis. Capital bypass direction. And sympathectomy, it's a palliative operation and irreversible procedure during which at least one sympathetic ganglion is removed. Lumbar sympathectomy, which is advised for weight loss of arthritis disease, in which lumbar 2 and lumbar 3 ganglia along with the interlinked sympathetic trunk are removed, leaving behind the L1 ganglion. Another example is endoscopic thoracic sympathectomy. On this picture you see the chemical sympathectomy is also possible, and use the 5 millimeters of phenol in water injected paravertebrally between the second and fourth lumbar vertebrae, contraindicated while using the anticoagulants. It goes to the retroperitoneal space. Don't need goes to the abdomen cavity. Make the way to the ganglions. You see the ureter And here you see the gremlin. Sympathetic thing. Usually this operation has a temporary effects, and it's a palliative operation. And last radical operation, it's amputation. And final stage for the severely affected limb with the Buerger disease is amputation. A study by corporates suspectedly assisted amputation rate in the 15 patients with Buerger disease listed in the Mayo Clinic patients and database from the January 1976 to December 1999. The authors concluded that the risk of amputations increased progressively in patients who continue to smoke, with the first amputation occurring an average 50.6 years after the diagnosis. The estimated risk is 25% at 5 years and 38 at 10 years and 46 at 20 years. And the risk of amputation high is 11% and 5 years and 21% and 10 years and 23 20 years. This study also suggests that the risk of amputation is eliminated after the 8 years of cessation of smoking. In a study by Sasaki and in a restricted population study of 850 patients in 1993, they reported that about of 20.2% of Buerger disease patients had some degree of amputations. It also reports a 2.73-fold increase in the risk of amputations among patients who remained smokers. Buerger disease, Thromboarteritis obliterans, is a debilitating vasculitis to the patients and challenging to the physician and as much to the diagnosis as to the treatment. Evidence for the efficacy of numerous therapeutic modalities until now is scarce, with a trend toward great efficacy of prostacyclin analogs in the treatment of more evidence levels of leuemia. Anonymity, however, refers only the role of smoking in this vasculitis, both at the beginnings of the disease and its perpetuation, making it essential to stimulate smoking cessation to minimize the damage of the disease. So thank you for your attention. Our lecture is over. You may be free.
Thank you, sir.
Thank you, sir. This is Daniel.